board on the computer. And so we're going to move away from muscles and how we control force. We're going to move away from muscular fitness, and we're going to start talking now about the cardiovascular system. Okay, and so we're going to do a little bit of cardiovascular stuff. We're going to do a little bit of the pulmonary or ventilatory system. Sometimes we collectively refer to that as the cardiorespiratory systems because they are in so many ways extrinsically linked, okay, or inextricably linked. Okay, so much of what we're going to do today, I'm sure you guys have seen. Okay, I'm sure that all of this was covered probably in significantly more depth, all right, in your anatomy and physiology courses. So a lot of this should be reviewed. I'm going to show you guys an EKG. I'm going to show you guys a picture of the heart, and we're going to briefly mention kind of what the chambers are and those things, but we're not going to get that in depth into how many flaps does each valve have and which coronary artery is this or that. Like, you guys have your anatomy textbook, or maybe you burned it in some kind of ceremony afterwards. Okay, we did that with organic chemistry books when I was an undergrad. So I want you all to know what these things kind of generally do and why they are important, much more so than I want you to understand kind of is it this one or this one? Is this the left circumflex or the right descending, whatever, okay? So I'll point out the things that I want you to know, but in general, we're going to focus more so kind of on function and bigger picture things, okay? The cardiovascular system is really, really important, okay? This is the system that, being sedentary, okay, not getting enough physical activity, and then conversely getting a lot of physical activity, this is one that is highly, highly affected. You could make an argument, other than simply the size of your skeletal muscle, the cardiovascular system is the one place, okay, where not getting enough activity kills you, because so many people die from cardiovascular disease. This system is really set up to function best when you're very, very active, okay? So it plays a role in a lot of different functions in the body, many of which support other physiological systems, okay? It circulates blood around, it moves nutrients and hormones and oxygen and all of these other things, okay? And so because of all of that, if the cardiovascular system fails us, then a host and a wide range of other functions are also going to fail us, right? Very, very, very large role in your ability to exercise, very large role in performance, okay, in who is going to be a good athlete, especially if it is anything that lasts longer than maybe like 10 or 15 seconds. It's any kind of an event that lasts longer than that, okay? Something outside of like, maybe I'm a 100-meter sprinter, or maybe I'm a long jumper, or maybe I'm a power lifter, but pretty much anything else, this plays a big role in some instances when you may not even think about it, okay? Because of this, there's a large number of adaptations that will take place in the cardiovascular system that help us to exercise, okay? It responds very, very positively to exercise. And unfortunately, it responds very negatively to not exercise, okay? So I am splitting function of the system into kind of these 5 very broad categories, okay? I'm not going to ask you to know any of this kind of in this way per se, but I do this to illustrate that when I say that it has this impact in this wide range of functions, you can see some of the things on here, and you may not ever really think that the cardiovascular system is important, but it really is, okay? There's the really obvious things that it functions to deliver oxygen and nutrients. So it brings oxygen from our environment in, or the lungs bring it in, but it gets it from the lungs and it takes it out to our tissue. It takes anything that you've eaten, okay, carbohydrates, lipids, proteins. It takes all of those things out of the digestive system and takes them off to other tissues where they can be used as energy. So it's really, really important for delivering things. You may even think about it as, oh yeah, it's useful for removal, especially of carbon dioxide. When we perform aerobic metabolism in mitochondria, we're going to turn oxygen and some sort of carbon-based molecule, okay, into ATP and water and carbon dioxide. And then we need to get rid of that CO2. And so it helps us to play some role in removing CO2. We'll talk a little bit more about that later. But then it does some other things that we may not always think about. It transports hormones, okay? Endocrine function is linked to function of the cardiovascular system, right? Because to be an endocrine organ, you got to release a hormone and it goes into the bloodstream and it can travel all around, right? So it transports hormones. That's really, really important, okay? So it plays some roles in people that are diabetics. It also plays a really important role in maintaining body temperature and internal pH, okay? You all may not think about it in this way, but if your cardiovascular system did not help you to dissipate heat, you would kill yourself by going to exercise and jogging for 45 minutes, okay? You would literally cook yourself if the cardiovascular system did not allow you to take heat and vasodilate and send blood out near your skin so that you can release some heat from there and then also provide some plasma that you can sweat off to remove heat, then you would cook yourself within 45 minutes to an hour. So it's this huge, huge important thing for body temperature. It also helps us to buffer acidity and kind of keep pH there. And then it also plays a role with infection and immune function, okay? In addition to having, say, lymph tissue that can move immune cells and things around, the cardiovascular system can also provide a conduit for macrophages, neutrophils, white blood cells, okay? It's going to provide a conduit for platelets and things so that we can actually close up cuts. It's going to carry things that are going to be released by the immune system, okay? Interleukins, things like that that are going to also help us with it. So it plays this really, really wide-ranging role, okay? Which is one of the reasons why, as there becomes more and more evidence that COVID actually can impact cardiovascular function, and that's one of the reasons why people that have cardiovascular disease, right, are going to be at a higher risk of dying. It's because COVID messes up kind of cardiovascular function. It causes inflammation around the heart. It causes improper blood vessel function. Okay, there's some evidence in the midst of all of that. And if you take people that have cardiovascular disease who that is already impaired, then it's going to, we can make it more heavy. The good thing is that with delivery and removal and maintenance and prevention, that kind of all of these things can be helped by the adaptations that occur following exercise and following physical activity. So there are three primary components in the cardiovascular system. I do want you to know what these three things are, okay? And we'll spend then a little bit of time talking about each one of them in some more depth, okay? So the primary kind of anatomical structures are going to be the heart, which is going to function simply as a pump, okay? It is, it's going to help us move the blood around, okay? You've got blood vessels, which are going to be channels or pipes or something, tubes, if you will. They're going to help us transport and move the blood around. And then probably the most underappreciated, in my mind, component of the cardiovascular system is blood itself, okay? You can argue that blood is a tissue. Blood is an anatomical structure. And it's going to be the fluid, and we'll loosely call it a fluid. It's a fluid that contains lots and lots of cells that are going to help us circulate, and those cells and that fluid are going to play a big role in transporting nutrients and removing CO2 and allowing us to kind of regulate body temperature and all of those things. Okay? Any questions about that so far? No, we're all doing good. We're okay there. Okay. Taylor's like, Dr. Black, move on. Like I got all this. I made 100 in anatomy. Like you're only talking about things that I already know. As she sits there. All right. Here's the heart. Okay. For my folks on Zoom, I want you guys at home to do all of this. Everybody here, I want you to take your left hand and make a fist and put it out in front of you. Okay? Then I want you to take that fist and I want you to set it just slightly to the left, okay, of your sternum, right about like so. I want your thumb pointing at your right shoulder, okay? Right shoulder. I want down here where this thing pointing at your left hip. So like this, okay? That is the size of your heart. That is its orientation in your chest right now. I'll get right here in front of the camera and blind myself. So it should look like this, my folks at home, okay? That's the way the heart is. Most of you on average, now I'm seeing lots of lights, okay? Your heart is about the size of your fist, okay? Give or take. And it's going to be oriented like so, okay? So here is your heart. Remember, you're looking into the body in this particular way. So the stuff that's on the right side of the picture is actually the left side of the heart. The stuff on the left side of the picture is actually the right side of the heart, okay? The heart is made up of 4 chambers. We're going to separate them based upon either being atria or ventricles, and if they're on the right or the left side of the heart, right? Blood is going to come back into the heart from what we call systemic circulation. So blood enters back into the heart, into the right atria. It then moves through some valve, okay? It's actually the tricuspid valve, but that doesn't matter for today, right? Into the right atria, right ventricle, and then it goes off to the lungs. It then comes back from the lungs into the left atria, into the left ventricle, and then it leaves out through the aorta, and it goes back into systemic circulation. That's it. That's all you got to know. That is the entirety of the anatomy of the heart that I want you to know. I want you to know the 4 chambers, and I want you to know kind of how the blood is going to move through those 4 chambers, okay? I also want you to know the relative state of oxygen, the level of oxygen in blood in each of these 4 kind of chambers. So we have relatively less oxygen in blood from systemic circulation, right in the right atria and the right ventricle. And then we have blood with relatively higher or more oxygen in blood comes back from the lungs into the left atria and into the left ventricle. Is that easy enough, guys? Y'all can do that? We can go down and ask the kids that are sitting outside waiting to go into anatomy lab right now. I'm sure Cindy makes everybody know way more than all of that, but that's all that I want you guys to know. Okay? All right. So that's all from a chamber standpoint. We're going to spend just a tiny amount of time talking about cardiac muscle itself. So the individual muscle fibers in or that make up the heart. Okay? So we're going to call cardiac muscle, it's called the myocardium. All right? Myo meaning muscle, cardia meaning heart. So it's heart muscle. Cardiac muscle is striated. It looks just like skeletal muscle under a microscope. Okay? That means it has sarcomeres, it has those very distinct striping patterns of actin and myosin within the sarcomere. Okay? It has a very, very extensive, often more so than skeletal muscle, it has a very extensive network of capillaries. Okay? This should tell us, right, that cardiac muscle needs lots of oxygen, it needs lots of blood flow. Okay? So lots of capillaries. Another piece that is going to separate cardiac muscle from skeletal muscle, and this again should be an area where structure tells us about and imparts function, is that about 40% of the cytoplasmic volume, so about 40% of the internal volume of a cardiac muscle fiber is occupied by mitochondria. That is compared to maybe 5, if you're really, really highly trained, maybe 10% of skeletal muscle, okay? So there's a huge amount of capillaries, there's a huge amount of mitochondria in cardiac muscle, and so that should tell us what? that should tell us that cardiac muscle is really, really good at using oxygen to make ATP. Okay? Your heart is not very fatigable, which is good for all of us, right? It's good for all of us. I've forgotten my embryology, okay, and exactly when we can kind of see a heartbeat, right, in a fetus. But for most of you guys, your heart's been beating for roughly 20 or 21 years straight, okay? You never think about it, it never really stops. Can you imagine if you've been doing curls like this? Just boom, boom, boom. I've been doing curls for the entirety of my life, okay? So I've been doing curls for 42 years. Just like, yep, what up? Here we go, curl. Can you imagine how big my freaking bicep would be at that point, right? Like, you're just all the time. That's what your heart is doing, okay? That's what your heart is doing. In some very rare circumstances, like when you have a heart attack, then you may get a lack of blood flow to the heart, and then it may become somewhat anaerobic, and that can be a problem. But because it has so many capillaries, because it has so many mitochondria, it never really gets tired. It never really has what we call sort of metabolic fatigue in the way that skeletal muscle does. Okay? So there's some specialized structures that are going to also be in cardiac muscle that we don't see in skeletal muscle. And I'll show you guys, I think there's some pictures in the next slide, but there are things called desmosomes and gap junctions that tend to occur at this place where one cardiac muscle fiber makes a connection to the next one, which is called an intercalated disc. Okay? So I do want you guys to know kind of these things that are going to be here on this particular slide. Okay? So here we have, this is just an H&E stain of cardiac muscle fibers. So for those of you guys that are at home, if you just want to pull up your slides and look at all of this, okay, you can see how they have this very, very nice striped pattern. They look just like skeletal muscle in that particular way. Okay, and so what you can see in these little areas where one fiber meets the next, this darker area, that is going to be this place here. That is the intercalated disc, where you've got one fiber that comes together and meets the adjacent fiber. Okay? At the intercalated disc, okay, you're going to have these specialized structures that are called desmosomes, which you can see here, and you're also going to have what are called gap junctions, which are basically just doorways or pores that are going to run from one side to the other. What you can note at the intercalated disc, though, is going to be that there's all of this kind of extra surface area to help it kind of lock together. It's really important that cardiac muscle is very closely bound together. All those fibers can kind of transmit things from one to the next. Okay? That's what desmosomes do. They help hold us together. And the gap junctions allow for quick and easy passage of ions and movement of ions from one cardiac muscle fiber to the adjacent muscle fiber. Okay? These are not structures that are found in skeletal muscle. And you guys will hopefully see in the next couple of slides why the ability to move ions from one fiber to the next is really important for the way in which we tell cardiac muscle to contract. Okay? Okay, so how does the heart contract? Well, cardiac tissue experiences what we would call this all or none principle, or an all or none contraction. Okay? And that is sometimes called synchronous contractions. So generally, under almost every circumstance, if one chamber of the heart starts to contract, then all of the other chambers will also contract. Now, there are some rare instances where that is not the case, and that is a very, very clear sign of pathology. Okay? So, all cells in cardiac tissue have something called intrinsic rhythmicity. Okay? Intrinsic rhythmicity means that they contract, okay? They depolarize and then will contract all by themselves, okay, on their own with no input from the nervous system in a very regular and predictable manner, okay? In a very regular and predictable manner. Kelly, you want to do something for us? Okay, can you stand up? We're going to do a fun trick. Okay. Kelly, can you get your heart rate on your watch? Is that possible? I know this is
I
just.
haven't updated it in a long time.
Oh no. Okay. Well, I should have brought my little pulse ox machine. That gives us things. So, in our fear over we've been exposed to COVID, we bought the little finger thing that measures your pulse oxygen. We put it on our daughter, like she thinks now, like we get up in the morning and she does this, and we put it on her little fingers. No, we got nothing. Okay, that's all right. Okay, here's what we want. Somebody tell me, okay, we're gonna change Kayla's heart rate, all right? As she stands there, boom, 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 heart is contracting, right? Like you're not a vampire, like we're sure that it's going. Can confirm, okay. That's part of why we need the thing. You guys have any ideas? How can we make her heart rate change? What should we have her do? Have her jump up and down. Okay, Kayla, do you mind jumping up and down?
Sure.
Okay, so do a little jumping for us.
How many times just keep
I don't know. Sarah? Do 3 or 4 for us. Do some jumps. Jump, 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 jump. It's impressive jumping in your Birkenstocks. Okay, very good. Sarah, what do you think that should have done to her heart rate? That should increase it, okay? Is there something else that we could do to increase her heart rate? What is that?
Give her a ripple.
Oh, Red Bull. I thought you said Ripple, and I was like, wait, what is Ripple?
Red Bull.
So we could give her some Red Bull, okay? That might be a way to do something, okay? Okay. Kayla, are you a singer?
No.
Perfect. Okay. If you guys think about asking her to stand up on her desk, don't stand on your desk. And I asked her to sing a song for us. You guys could pick a song. We could make her sing a song. Might that increase her heart rate? Yes. Okay. Is there a way that we can make it go down? Do you have any ideas to make her heart rate go down? You don't know? You're just stuck. We can't ever do it? Okay. She could sit down. She could meditate, right? Like we could put her in one of these rooms where it's nice and dark. We could wipe off one of these nasty mats or something and have like go in there and lay down and chill out, right? That might make her heart rate. Thank you, Kelly. You can sit. So how does that happen? If her cardiac cells intrinsically will depolarize without any external input, then how do we have the possibility, and why do we have the possibility to make that either fire faster or slower? Any guesses?
The heart rate can still be affected by the nervous system, like the hormones released.
Okay.
Nervous system, even the intrinsic rhythm.
Okay, that's good. Sorry, so that's right. Okay. The individual cells will fire. In the absence of any input from anywhere, they will fire at some particular rate. Okay. However, based upon other ways in which the cardiac system is set up, we do have some ability to influence what's going on. Okay. And so that is called the cardiac conduction system. And the fact that it's going to kind of spontaneously contract is called autoconduction. So what happens is that the cardiac conduction system, which partially controls autoconduction or can kind of supersede autoconduction, we can alter heart rate. We can alter it very, very quickly. We can make it go up. We can make it go down. Okay? Depending upon some other things. For most of you guys, in the absence of any kind of input from anything, okay, which never happens, by the way, this never happens. Intrinsic firing rate of the cardiac muscle cells is about 72 beats per minute. Okay? So it's a little bit more than 1 action potential per second. Okay? That's the intrinsic firing. So the way that the conduction system works, though, is that we're going to use these collection of kind of nerve fibers or nerve bundles that are located in a couple of places. And we're going to use input into those, which also have their own intrinsic firing rate, to help us kind of apply some level of rhythmicity and some level of input to the actual cardiac muscle. And that's why heart rate's rarely ever just exactly 72 beats per minute. Okay? Does that make sense, guys? Okay? So you've probably seen all of these different things. I do want you to know the relative location and kind of the relative control of these 4 components of the cardiac conduction system. I don't necessarily want to say that one of these is more important than the others, but the one that is the primary control center for heart rate is something called the sinoatrial node, or the SA node. Okay? The SA node is located in kind of the top portion of the right atrium. So you can see it right here. Okay? SA node is here. This is what is sometimes referred to as the pacemaker of the heart. This is the structure that is the primary control of what your heart rate is. Okay? And that's typically because it's the first place. It's the first thing that might contract, the first thing that might fire, and then it can put some exert influence on everything else. Okay? So we're going to get in the SA node, it is going to generate action potentials. And it will do this spontaneously, again, at about 72 beats per minute here. It will do this spontaneously because it has a leaky sodium channel. We're not going to get into how we generate action potentials and all of that, but sodium leaks in and will cause it to depolarize. Okay, so you get a signal at the SA node. Cardiac muscle, like skeletal muscle, is excitatory. And what that means is that an action potential generated in one place on cardiac muscle, it will spread in every direction out from that place and spread out to all of the rest of the cardiac muscle. So depolarization occurs at the SA node. It spreads all through the rest of the right atria and also over into the left atria. Okay? It's like dominoes. You stack them all up, you knock one down, boom, 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 off it goes. Okay? Now, the kind of next place in the cardiac conduction system is something called the AV node, or the atrioventricular node, which is located also in the right atria. It's really going to be in the wall of the right atria, right where it meets the right ventricle. So action potential from the SA node, boom, it's spreading across the atria, which means the atria will contract. Okay? They're going to contract pretty much simultaneously, left and right here. Okay? Then that's going to send blood right into the ventricles. Then we're going to get depolarization of the AV node. The AV node is connected with some nerve bundles to these nerve fibers that run down the septum of the heart. This is called the AV bundle, or the bundle of His, even though His is spelled H-I-S. Okay? It spreads them down towards the apex of the heart, so it moves down here to the bottom. Then those fibers are going to split and turn and kind of rotate back up. From the bottom of the heart, they're going to be these finger-like structures that are going to kind of wrap themselves around the ventricles. Those are called Purkinje fibers. Okay? And Purkinje fibers in the AV bundle are going to allow very, very fast transmission. So action potentials will move faster through the bundle of His and the Purkinje fibers than they would kind of along the cardiac muscle that might have been, if these ventricles are adjacent to the atria. If you get any kind of spillover, basically, from this piece of cardiac muscle into the ventricles, this goes much, much faster, so it can kind of supersede. Okay? And so what this does is it moves the action potential to the bottom, and then it brings it up. So that what happens is that the ventricles tend to contract from the bottom up, which if you look at how and where, right, where pulmonary arteries and the aorta are going to be, that makes sense. They are approximately above, okay, the ventricle. So the ventricle contracts from the bottom and it kind of squeezes stuff up from the bottom and pushes it out into the aorta and so forth. Okay? Does that make sense? I'm sure you guys have seen all of that before. Okay. So the thing is, if we want to control heart rate, we need to do something to the intrinsic firing rate here in the SA node. Okay? And so, I'm not talking about that at all. Oh, we don't even talk about that. Ha! Okay, I may not talk about it yet in the midst of this. But we can apply things from especially the sympathetic and the parasympathetic nervous system. We can apply input into the SA node, and we can make your heart rate go up or go down. Okay? So if we do anything that increases sympathetic nervous system input to the SA node, I could do something to embarrass you or to stress you out. We could start exercising. Okay, this is going to release epinephrine and norepinephrine. Heart rate goes up. Or if we do something where we can get it to release acetylcholine, parasympathetic input, we can depress the firing rate and we can make it go down. Okay, so I think there's a slide about that a little bit later on, but we'll come to that as we get to it. Okay. So when a heart contracts, or when the heart contracts, we call that a cardiac cycle. Okay? So think of a cardiac cycle as what happens during one heartbeat. Okay? So during a cardiac cycle, each individual chamber of the heart undergoes a period of contraction that we call systole and a period of relaxation called diastole. Okay? Both of these things are absolutely 100% key and important to cardiovascular system function. Okay? If we don't get a long enough or strong enough period of systole, we cannot move blood within the cardiovascular system. Okay? The atria don't contract forcefully enough, they can't move blood into the ventricles. If the ventricles don't contract forcefully enough, we can't move blood into the lungs, or we can't move blood into systemic circulation. Conversely though, right, if our period of relaxation or diastole is impaired, most often because it doesn't last long enough, then that's going to prevent that chamber from filling up with blood. If the atria never relax, we cannot get blood into the atria. If the ventricles never relax, we cannot get blood into the ventricles. If we can't fill the heart chamber up, then we can't move the blood from one place to another. Okay? So both of these two things are really, really important. And very often as heart rate changes, okay, as heart rate goes up and heart rate goes down in response to different things, as contraction force of the heart changes, these two things, these two parameters will change in very predictable ways. Okay? All right. So at rest, okay, about 60% of a cardiac cycle is spent during relaxation compared to about 40% of the time will it be contracted. So when you're resting, which most of you guys are now, maybe some of you guys on Zoom are like resting too much. Maybe you're like in your bed, like all laid out, just chilling. Okay, which is fine, but about 60% of the cardiac cycle is spent in diastole, okay, and about 40% there. This is good in a scenario whereby diastole exceeds systole. We should have plenty of time for blood to fill into our individual chambers. Okay, so at 75 beats per minute, an entire cardiac cycle takes about 0.8 of a second. Okay? So you can take all of this, and of our 0.8 of a second, we're going to spend about 0.5 of a second, right, in diastole, and about 0.3 of a second or thereabouts during systole. Okay? Okay. So that's a cardiac cycle. During one cardiac cycle, we can measure, okay, we can measure the movement of action potentials from kind of around the heart or through the cardiac conduction system by performing something that's called an electrocardiogram, which is sometimes called an EKG. I don't know where the hell the K comes from. It is other times called an ECG, so electrocardiogram, okay? And I'm looking around for what we've done with our EKG machine. It should have been on one of these computer things that was here. But if you take exercise testing and prescription with Dr. Larson or Dr. Kellerwan, you guys will get to do EKGs, okay? EKGs are really, really interesting and really, really useful diagnostic tools for screening people and studying cardiovascular disease. Also, if you don't want to have to fight with people over going to PT school or OT school or PA school, but you'd like to have a job where you work about the same hours with about the same patient population, and in some instances make more money. You can do something called cardiac rehabilitation. So if you can learn to read and interpret EKGs, what you do is you do exercise programming and you monitor the safety of people after they've had a heart attack, right? If you like working with older people, you like old folks, okay? They're kind of fun. They just like people to chat with them and those things, okay? But you can learn how to read all of these, and you can go and get a master's degree in clinical exercise physiology, and you can run cardiac rehab programs, which basically every hospital in the country has one of these. There's lots of outpatient ones as well. This is the standard of care for people that are post-heart attack. Is they do cardiac rehab. Somebody has to supervise them. Okay, so an electrocardiogram is a printout of the electrical activity of the heart, okay? So what we do is we stick electrodes on your chest, sort of around your heart. We put a couple on your back. We put one over here, depending upon how many, we call them leads, how many of them we want to do. The standard diagnostic one has 12 electrodes. So we go all around the heart. We go all around. This lets us then kind of get a three-dimensional picture of sort of right and left atrial function, right and left ventricular function. It will let us, we can look at how the EKG looks, and we can kind of hone in that it's catching this particular chamber of the heart, which is going to be really, really helpful. Okay? So with an EKG, I'm sure you guys have seen all of this before. Anybody in, or are you teaching chronic disease this semester? Anybody in or taking the chronic disease class? Just one. Did y'all do EKGs in chronic disease? No? Okay. Did you have it last year with the summer? Who taught it in the summer? Taylor did. Okay. She's like, some TA. So I used to teach it in the summer, but when I taught chronic disease, we still did EKGs. And then we switched the class around, and we're not doing it anymore. But this is an EKG. In chronic disease, you usually have to pick out like what different pathologies look like. Do you guys see actual reported EKGs in anatomy or in physiology? Y'all do a lab where you have to look at them and interpret them and like decide like, is this right? Is this AV block, or is this like third degree S&T segment depression or anything else? And one of those things like that. Anyway, in chronic disease, people like literally like throw things at me. It's so bad. But what you can see here is this is 2 cardiac cycles. Okay, here to here this is 1 cardiac cycle. This is a second cardiac cycle. Typically, we measure your heart rate by measuring from what's called the top of this R wave, R to R intervals. You would count up how many of those you get in a given period of time to calculate heart rate. Okay. So each of the kind of changes in shape, each of these things represent electrical activity within the heart. Each one of these things represent a very distinct event that is occurring in the heart. Okay. So they typically start with what's called a P wave. I don't know why it's called a P wave, but it represents the polarization of the atria. So this is SA node fires, atria depolarized, you get a little hump. It's then going to spread through the AV node, down the bundle of His, and we're going to get Purkinje fibers, and we're going to get what's called a QRS complex. This represents ventricular depolarization, so the ventricles are firing. They're going to contract right after this, okay? Then you get what we can measure here is called a T wave, and that represents the repolarizing of the ventricles. Atria repolarized, but it's hidden in the QRS complex, okay? So that's what each one of these things represents. And so if you have a problem with your SA node, your EKG looks a certain way. If you have a problem at the AV node in your cardiac conduction system, this looks a very certain way, okay? If you have a lack of blood flow going to the ventricles, which is one of the most common things that happens when people that have had a heart attack, if you have blockages in your coronary arteries, this thing here from S to T, this little what's called S and T segment, this little thing gets depressed down and it looks more like this, okay? It's called S and T segment depression. If you have S and T segment depression, you've either just had a heart attack or you are at very, very high risk of about to have a heart attack, okay? It's very, very diagnostic. Okay? So if you can read these and interpret and understand these things in real time, then you're basically ready to be a cardiologist. Okay? So that's kind of what's going on here. All of this. Okay, now just going to kind of show us what those things are. How are we doing on time? We'll talk about stroke volume, and then we'll take a little break. Okay. All right. So we've covered heart rate to some extent. Okay, the number of times your heart beats in a minute. Okay, or any period of time, pick it out, whatever you want to call it. Okay. One of our other really, really important parameters of cardiac function is something called stroke volume. Okay. Stroke volume is the amount of blood that gets pumped out of the left ventricle every time the heart beats. Okay. Every time the heart beats. It tends to be, in an average sized person, about 80 milliliters of blood per beat. Okay? Now, you guys may ask, well, Dr. Black, what is 80 milliliters? What does that look like? Okay? And so there's not very many of you guys that are here. This analogy becomes less and less useful to me as we go along and then illustrate my age. By a show of hands, has anybody used a camera in your life that takes actual 35 millimeter film? A real camera, not your phone. No, yes, no, maybe, kind of. Also can't be one of the disposable ones that they put on the tables at weddings and things. Don't do that. You're not going to like what you get at the end on some of those kinds of things. We did that. I'm reminded of that. So my wife and I, our wedding anniversary was yesterday. Okay, 17 years we've been married. Yesterday. How did we celebrate? We sat on the couch and had takeout food without our child being awake for like the first time in like 6 months. It's crazy. That's what we call a sit-down meal with the Black household these days. Okay, 35 millimeter film. If you expose it to light, it ruins it. Okay, I had a class with my wife in college where it was a photography class. We had to take pictures and then go and develop the film ourselves in a dark room and these things. But the film used to come, so I'm digressing. The film used to come in these little black canisters that had a gray top on them. They're about this tall, okay? It was about this tall, and they're about yay big around, okay? That would hold about 80 milliliters of a fluid, okay? But now that nobody knows what a real camera looks like, or nobody knows what actual 35 millimeter, like you go buy a 35 millimeter film, it's not going to come in that. So my hand sanitizer bottle here will contain, it says 237 milliliters, so it would be about a third of this bottle. So about right there, okay? On the bottom, that's about how much blood leaves your heart every time the left ventricle beats. Okay? So this is probably going to be more confusing than it needs to be. But we can calculate stroke volume by subtracting two variables from each other. One of those is called end diastolic volume, the other one is called end systolic volume. Okay? And so what I will do, usually I would just borrow a couple of water bottles from people in class, but for today, we'll use our two things of hand sanitizer that are going to be here. Okay? So imagine what I have here, okay? Big hand sanitizer, okay? This is my left ventricle, all right? It's just contracted. You will note, for those of you that are in class, maybe that it doesn't have that much. It does not have very much in there, okay? This, after contraction, the amount of sanitizer in here, if it was blood, we would call this end systolic volume, okay? We squeezed it, when the heart beats, we squeeze it, and then some amount came out, and then whatever's left in there, that is end systolic volume, okay? Now, it has now relaxed. I'm going to take hand sanitizer from my other bottle, okay, and I'm going to pour it in here, and I'm going to fill it up to a certain place. So it's relaxed. The right atria, the left atria is contracting, and it's pushing some blood back in here, and we're going to fill it up to a certain place. Okay? Let's just say it comes up to here. Then it contracts again, so it's filled up. That's my end diastolic volume, so it's filled up while it was relaxing. Then I squeeze again, and some amount leaves. Okay? If I know where it was before it began contracting, and I know where how much blood was in there when it stopped contracting, the difference between those two is stroke volume. The amount that leaves during contraction is stroke volume. Okay? We can measure this by doing ultrasound imaging. If we really can really try to get at it, we can measure it with ultrasound imaging during what's called an Electrocardiogram. The easier way to measure all of this is we run a cardiac catheter. Usually we stick it in your femoral artery and thread it all the way up to the aorta. We thread it all the way up through the system into the aorta, and then it has a little measuring, like a little thing that will measure the amount of blood that goes by it in a certain period of time, and so we can measure flow basically over time. If we know your heart rate and we know how much flow is going by, we can calculate stroke volume. Okay, very invasive, very difficult to measure. We can also infer it by doing some crazy calculations, by having you do an exercise valve. We hook you up to a big balloon that has carbon dioxide in it, and you breathe into the balloon. So you breathe out your CO2 into the balloon, and then you breathe it back in. And we can judge by how much the CO2 is going up, and we know what your heart rate is and some stuff, or we can do some calculations and estimate stroke volume from all of that. It's very hard to measure stroke volume. It's a very long-winded answer and a kind of explanation, but all I really want you guys to know is the blood that leaves the heart every time it beats is called stroke volume, okay? That's called stroke volume. Why is stroke volume important? Well, if you let me, among all of you in here, okay, if you let me have one physiological measure that I can make to guess, okay, at which one of you would be the best endurance athlete, I would pick stroke volume relative to your body size, okay? Whichever one of you is able to eject the most blood from your left ventricle, okay? Heart size is generally relative to body size. And so if I know those two kinds of things, whoever's got the relatively largest amount of stroke volume, you're probably going to be the best endurance athlete. And we'll talk a little bit more about why that's going to be the case kind of later on. Okay? When we do exercise training, you're going to experience cardiac hypertrophy, especially left ventricular hypertrophy. So the left ventricle gets bigger. Okay? As it gets bigger, you can fit more blood in, so end diastolic volume can go up. And as it gets bigger, it can contract more forcefully, which means it can squirt more out, which will make in systolic volume get lower. So this gets bigger, this gets lower, stroke volume goes up. Okay? People that do a lot of aerobic exercise are going to have a relatively larger stroke volumes than other people. People that have cardiovascular disease have small stroke volume. Okay? People that have like congestive heart failure and things have very, very small stroke volume for a host of reasons. And that can be really dangerous. Okay? All right, questions about that? Y'all gonna get on eBay now and like buy an old 35mm camera or something? Nobody wants one of those? The pictures they take are really shitty. Like you gotta sit the camera still, you gotta focus it all by yourself if you want to. Like, you know, it makes all the fun things you can do on your phone now. Like the phone takes way better pictures than like those old 35mm cameras used to. So that way technology is great. Okay, let's take a break. We're gonna pause, we're gonna take a break. Let's come back at, let's call it 12:05. Okay, we'll start back again at 12:05. Okay, so we'll get started back up again. So what we're going to do now is talk about kind of probably one of the most predictive other manners and ways that we measure cardiovascular function, something called cardiac output. Cardiac output is the product of heart rate and stroke volume. So if stroke volume is the amount of blood that leaves the heart every beat, cardiac output is the amount of blood that leaves the heart every minute, or every 5 minutes, or every 10 minutes, okay? And so cardiac output is abbreviated as Q, and so it is equal to heart rate multiplied by stroke volume. So the number of beats that you're going to experience in 1 minute multiplied by the amount of blood that leaves the heart each minute, okay? In a typical kind of average size college-aged person, cardiac output is going to be somewhere between maybe 4 or 5 and about 6 liters of blood per minute, okay, that is going to be pumped out of your heart. So what that means is that every minute, okay, every minute, 3 2-liter like jugs of blood is going to get pumped through your heart. Okay? So for most people, your total blood volume is going to be pretty close to what your resting cardiac output is. Okay? So in kind of an average college-aged male, resting blood volume is about 6 liters of blood, and resting cardiac output is about 6 liters of blood per minute. So for most people, all of the blood in your body is going to pass through the heart about once per minute at rest. Okay? So during exercise, okay, cardiac output may increase 4 or 5-fold. It's going to tend to go from maybe 5 liters per minute at rest up to maybe 20 liters per minute during high intensity exercise. Okay? So your blood volume doesn't change. What that means is that as the heart beats faster, and as it beats more forcefully, then we're just going to move more blood, move the same blood through the heart faster and faster, so that a larger amount is going to get through there every minute. In very, very elite, especially like large distance athletes, okay, cyclists, okay, who tend to be a little bigger than like cross-country runners or marathon runners. Anybody ever been cross-country skiing? Anybody ever done cross-country skiing? I got nobody? Don't start. It's terrible. Okay. I've never actually been. We had a thing at my house when I was little. I can't even do it now. It's called a Nordic track, and it was like a treadmill for cross-country skiing. So you had to like match up, like we swing your arms and things. So cross-country skiing, the folks that are really, really good at it tend to be very big, because it involves like upper body pushing and lower body things. So you get these kind of Nordic athletes who are 6'3", 6'4" guys that weigh 225 pounds or something. There's just these giant humans, okay? Women that are really good, look like, women maybe 6'1" or 6'2" and, weigh up, 180 pounds or 190 pounds. There's these very, very large athletes. They're going to have these kind of elite kind of cardiac outputs that may be in the low 30s to maybe 35 liters per minute, okay? Cardiac output is the person that has the highest cardiac output, the largest ability to move blood through the heart to reoxygenate it and get it back out again. The larger your cardiac output, the better the endurance athlete you're going to be, okay? You guys will see a little bit later on that cardiac output is directly related to a parameter called VO2 max, or the maximal volume of oxygen that your muscles can use to make energy, okay? So big cardiac output, primarily related to big stroke volume, okay? As we will see. So cardiac output increases during exercise up to a point. You cannot increase it endlessly, right? There is a maximal stroke volume for everybody. There is a maximal heart rate for everybody. So there's going to be some limits on all of these kinds of things, okay? Okay. So we're going to step away from that and talk about a couple of other ones. This is one you guys have probably already know quite a bit about. We used to do a lab where we would measure it, and then we figured out that like all the other classes do the same lab as well. And that's called blood pressure, okay? Let me explain to you guys before we talk about what it is, why blood pressure matters, okay? Why should you give a shit about blood pressure? Well, blood is a fluid, okay? Blood is a fluid. The movement of fluids in your body is entirely governed by pressure and pressure gradients, okay? And so the pressure that the blood exerts on a particular artery in a particular location in your body is going to play a large role in determining if blood can move into or out of that particular structure or that particular location in your body, okay? So in general, when we talk about blood pressure, we express it as two numbers: systolic pressure, or the pressure exerted against a blood vessel wall while the left ventricle is contracting, and what we call diastolic pressure, or the pressure exerted against the blood vessel wall while the left ventricle is relaxed. So you have systolic and diastolic pressure, okay? And so systolic most often is going to be higher than diastolic. If it's not, we got big problems, okay? So the heart is actively contracting, that gets us our systolic pressure. You can think of systolic pressure as what we might term driving pressure, okay? This, because it's going to be the higher one, this is the pressure that determines how much oomph basically there is to push the blood along, okay? Diastolic pressure, because it is during filling of the left ventricle, this is the relaxed pressure inside of a blood vessel, okay? And so for blood to move, there must be a difference in systolic and diastolic pressure, and in some instances, there must be a difference in systolic pressure in one place in your body and some other place, okay? So we don't see this kind of talked about very often anymore, but I do want to at least introduce this as a concept because you may encounter it. And it's something called mean arterial pressure. Mean arterial pressure is the average pressure through a particular blood vessel over one entire cardiac cycle, okay? So for instance, at rest, mean arterial pressure is going to be about 1/3 systolic pressure, 2/3 diastolic pressure, okay? And so it's just a way of trying to estimate the average pressure seen by a blood vessel, okay? It is somewhat fallen out of favor kind of as a measure in the kind of cardiovascular disease and the cardiovascular exercise physiology literature. It was much more in use in the 70s and the 80s and those kinds of things. So systolic, diastolic. How many of you guys have taken blood pressures before? A couple of you have? Okay, maybe we should do it in lab. Taking blood pressure, it's not that hard. We can teach you how to do it pretty easily with a little bit of like a couple of days of practice. I could make most of you guys reasonably adept at doing it at rest in people. But we don't do it very often anymore because we just slap a thing on you and there are computers that do it for us, right? So we're going to get there. The reason that blood pressure, again, is going to be really important and kind of how it's going to shift over within a cardiac cycle and how it's going to shift from one location of the body to the next is going to allow us to move blood in the body. Okay? So what you see in our graph here is going to be, this is pressure inside the left ventricle, pressure in our arteries, pressure in arterioles, so kind of arteries that have gotten much, much smaller, pressure in capillaries, pressure in venules and veins, and then pressure back in the right atrium. And so what I want you to note is that where it oscillates here, it's showing diastolic pressure at the bottom. So when the left ventricle is relaxed, there's almost no pressure in the left ventricle. When it contracts, it goes way up here, okay? Then we're going to get out into our arteries. It's going to leave, right? It leaves the heart in the aorta. The aorta is going to come out, right? And I've forgotten which one runs across here in my shoulder. And then we typically measure it in the brachial artery out here in our bicep, okay? So kind of see here, this is what's happening, and it's going to go up and down. Once we get out here, there's always going to be some blood, so our diastolic pressure doesn't go nearly as low as it does in the ventricles. But we've got this rhythmic thing. What I want you to notice as we move from arteries into arterioles and into capillaries and veins and venules is that the pressure falls, okay? Blood moves from areas of high pressure to areas of low pressure, okay? High pressure to low pressure. And so what this illustrates is that blood is going to get driven because of the differences in pressure out of the left ventricle, into our arteries, into arterioles, down into the capillaries, then into the veins and the venules, and then back into the right atrium. Where at rest, there is basically no pressure in the right atrium. Okay? If something happens, which it will with aging and cardiovascular disease, where especially here on the artery and arteriole side, okay, where we can't get this natural decline in pressure across these things, then it becomes much, much more difficult for blood to move from one place to another. Okay? And so when we get into cardiovascular disease, we'll talk about what is changing that is kind of preventing some of this normal, natural decline in pressure. Or why, as kind of resting pressures go up, is that bad for the heart and also kind of bad in our blood vessels? Okay. Everybody with me? Is that okay? If we don't have a pressure gradient, then that's going to be a problem. All right, now we're going to talk about blood. Okay. Of all the other things, blood's probably my favorite. Probably shouldn't be. If my wife sees blood, she passes out. So it's a fun time at the Black household. Actually, for her, you can take her and you can just tap the inside, the crook of her elbow. You can just tap her right here and she'll pass out. And she will faint. Okay. We had to give blood several times when she was pregnant. We got because we were, old parents, we got some of the advanced genetic testing done. There were some other things they had to do. And she had to do they had to draw blood to check and see if there was gestational diabetes and things. She just psyched herself up for 2 weeks to kind of get ready for all of that. Right? So I like blood. I don't like seeing blood, but I like the idea of what's kind of going on in blood because it's really, really important for exercise. So blood is generally thought of as a fluid, okay? but it also has something that we call hematocrit in it. So blood is plasma, so the fluid part of blood is basically water, and that tends to be somewhere between maybe 50 and 60% of its overall volume of the blood, okay? So blood is water plus what we call hematocrit, which is going to be red blood cells, white blood cells, and platelets, okay? And this may range somewhere between like 40 to 50%, 35 to 50% of the overall volume that's going to be in here, okay? The vast, vast majority of hematocrit, like 99% of hematocrit, are going to be red blood cells, okay? The water in here is absolutely essential, and the red blood cells in here are absolutely essential for normal function, okay? So if we draw blood, we put it in a test tube, you can put it in a centrifuge and spin it, okay? And then you can pour off the plasma, and you've got the red cells and the white cells and things that are left at the bottom. Do y'all do anything like that in physiology class, where they did like a finger stick and put it in a little bitty capillary tube, and then you can sling the capillary tube around, and it spins, and you can estimate, you can kind of estimate what this is going to be. Okay. A quick note on what we call plasma volume and hematocrit as a percentage of total volume. So changing your hematocrit percentage, having more or less red blood cells, can be a very powerful way to improve your exercise performance in endurance events. Okay? If you have more red blood cells, you can put more oxygen in your blood, which means you can take more oxygen to your muscles. Okay? So there are these natural ranges. Most of you guys have a hematocrit percentage that's probably somewhere between like 40 and 42 or 43% of your blood is going to be red blood cells. If I send you to altitude, okay, I'm going to send you guys to Colorado Springs, and you're going to go camp out kind of up on Pikes Peak for, I don't know, like 2 weeks or something, your hematocrit percentage will go up. You go to altitude and it can go up. And you guys, if you're at 40 normally, you may go up to 45 or 46. If you're at 45 normally, you may go up to about 50 or thereabouts, okay? However, if I give you a hormone called erythropoietin, right, which is typically made by your kidneys, stimulates bone marrow to make red blood cells. If I give you that artificially, I can drive up the amount of red blood cells that you have, okay? So you guys may have heard of erythropoietin. It's called EPO. This is the thing that Lance Armstrong took that made him Lance Armstrong. Okay. Now we can argue that all the other cyclists were also taking EPO. Anybody watched the end of the Tour de France this week? Sorry, you did. Okay. So it's an amazing. Whether those guys are doping or not, it's an amazing thing to ride a bike for 3 straight weeks over thousands and thousands of miles and climb mountains and all of that stuff. It's nuts. Okay. If you take EPO, your hematocrit percentage may get into can get into the mid-50s or even up to 60. It's extremely dangerous. It's extremely dangerous because as you get more hematocrit, your blood becomes thick and really sludgy. And then when you go to sleep at night, it clots. And so you got to be really, really careful. So what they do now for endurance athletes, if you ride the Tour de France or you are a professional distance runner, they have what's called a physiological passport. And so they can call you any day, any time throughout the year, and you have to go within like 8 hours or something and give blood and allow them to check your hematocrit percentage along with some other things, okay? And what they do is they know that under normal physiological conditions, even if you go and you live at altitude or you train at altitude, that you typically cannot ever get more than about 52% of a hematocrit percentage. And so if you're ever over that, then that is a sign that you're doping, you're taking erythropoietin. And so this is one of the ways that they try to do this. They try to do this testing year round, and like you get a baseline for you in the off season, and they kind of, you got to check in about where you're going, and they really do this because you can take the EPO, and synthetic EPO looks just like regular, like normal bodily made EPO, like we can't track EPO levels, those kinds of things. So that's why this is important, okay? It's really important for exercise because this lets you carry oxygen. But then the plasma is also really, really important because you need the plasma to be able to sweat and dissipate heat. So if you exercise when it's hot outside, or you just go and stand outside, when it's hot, you actually will get more plasma. You'll get more water in your blood as well, and that allows you to sweat off more, and that's also a really good positive adaptation. Okay, so why do the red blood cells matter so much? Why do we care if your hematocrit percentage goes up? Why is that good for exercise? Well, it all comes down to their function of red blood cells, right? So here's our little red blood cells. It looks like a little red donut in some ways without the hole in the middle. So the function of red blood cells are very, very simple. Carry oxygen, okay? Carry oxygen. Red blood cells have something in them called hemoglobin, okay? And having a hemoglobin, so you have millions and millions, when I say million, like 250 million molecules of hemoglobin per red blood cell. So each hemoglobin molecule can bind 4 molecules of oxygen. Hemoglobin has iron in it, okay? It has iron in it. Anybody remember your chemistry and what the charge on iron is? Everybody remembers? Okay. Iron has a +2 charge on it, and so it is very, very powerfully attracted to sort of negatively charged things. So it's going to help us bind oxygen by having the iron in it, okay? So you put 4 molecules of oxygen onto a hemoglobin, you got 250 million hemoglobins per red blood cell, so you can put basically 1 billion molecules of oxygen on one red blood cell. You have millions of red blood cells in your body, millions of them, okay? So red blood cells turn over in your body somewhere between about 90 to 120 days, so you're always breaking down and having some red blood cells die off and making some new ones, okay? But so by doing all of this stuff, I should back up. So its purpose is to transport oxygen. By having red blood cells with hemoglobin, you can carry, like, I don't know what the numbers are. I should off the top of my head. It's like 5 or 10 times more oxygen in your blood, or 20 times more oxygen in your blood, a huge amount more oxygen than if we just had to dissolve the oxygen into the plasma in the blood. Okay? So, sorry, 70 times more. I apologize. Okay? So, when we carry oxygen in your blood, about 98% is bound to hemoglobin, and about 2% is dissolved in the blood into water. Okay? And put a little bit of oxygen in the blood. So, this marked improvement in your ability to carry oxygen. So, let's say you're anemic. You don't have enough red blood cells, you don't have enough hemoglobin in that way, your oxygen carrying capacity is going to fall. That's not great, okay? If you can take something and make it go up, then you can carry more oxygen, and that can potentially be a very, very positive thing. So one of the ways that we can try to understand how hemoglobin works and how oxygen is being carried is by looking at a parameter called hemoglobin saturation. And again, because we had to hide it from my daughter this morning, I should have brought it. But you go to the doctor, they put the little thing on your finger, and it shines what's called near infrared light into the blood going through the capillaries in your finger, and it will either bounce off or absorb light at certain wavelengths, and we can measure the amount of hemoglobin in your blood that has oxygen bound to it. We call that hemoglobin saturation. Typically at rest, an average person is going to be somewhere between 95 and maybe 99% saturated, okay? When you exercise or you go to altitude, you do something where you need more oxygen or there is less oxygen available, hemoglobin saturation is going to fall, okay? It's going to fall to an extent, okay? if you look at someone that has a pulmonary problem, they have emphysema, they have chronic obstructive pulmonary disease, they have asthma or something, because their lungs don't work properly, they can't bring the oxygen into their lungs, so their hemoglobin saturation will fall because of that. Apparently one of the most predictive measures of when a person with COVID needs to go and get admitted to the ICU at the hospital, and then is going to need to get put on a ventilator, which is the really kind of bad and dangerous things, is a precipitous fall in their hemoglobin saturation. So you can watch their hemoglobin saturation, and it will begin to dip a couple of days before things get really bad and they need to go to the ICU. Okay, so that's kind of what all is going on. 98% is way more than what our bodies actually require. Okay, you can usually do okay, kind of even down into the low 90s and not notice any real kind of differences. Okay, so because of this, because hemoglobin saturation tends to be so high, under most circumstances, the ability of the blood to carry oxygen, okay, is rarely going to be a limiting factor for exercise performance. And for people that have normal pulmonary function, as long as you're not at altitude, okay, altitude changes things, impaired pulmonary function changes things. As long as those two things aren't present, you shouldn't have any problems because you're not able to get enough oxygen onto your hemoglobin. Okay. Now, in some elite athletes, that's not always going to be the case. If you have some other kind of impairment, that's not always going to be the case. But in general, oxygen in your blood is not going to be an issue. Okay. Let's talk about the converse. Let's talk about CO2 transport. Okay. So, in your muscle tissue, you're going to take all of that oxygen and you're going to metabolize it, and you're going to make carbon dioxide. We then have to get the carbon dioxide out of our muscles into the blood and circulate it back through our veins, back to the lungs, so that we can breathe off that CO2. Okay? So how are we going to carry CO2 in the blood? Well, some of it just gets dissolved into the water in the plasma. Okay? So we're going to put CO2 in there. So in some ways, venous blood is like a very, very, very flat, weak form of sodium bicarbonate. You guys know what that is? That's basically when you put carbonation in a beverage. So it's like seltzer water or something. If you let it sit out and go flat, it's a very small amount that's in there. You're going to bind some CO2 onto hemoglobin, somewhere between maybe 20% to about 30%, which is called carbaminohemoglobin. Okay, carbaminohemoglobin. The rest, okay, which may be somewhere between 60 to 70%, is going to be stored in the blood as something called bicarbonate. Okay, when you put CO2 in water, again, more chemistry, it forms carbonic acid. Carbonic acid is a weak acid. Well, when you put acid in plasma is mostly water. When you put an acid in water, it dissociates. And so it becomes this hydrogen, this free hydrogen ion, and then HCO-, which is called bicarbonate. Okay? You guys know what bicarbonate is? You guys know what bicarbonate does? Some of you may have ingested bicarbonate for a medical-ish reason in the last couple of weeks. Anybody know? Okay. Anybody ever taken Tums or Maalox, or I don't know what the other kind of forms of, sort of, if you feel like you have an upset stomach or something, or you've got heartburn, right? You take Tums. Tums is bicarbonate. That's what it is. Bicarbonate is a base. Its job is to neutralize or buffer acids. Okay? So in this way, especially venous blood is going to have bicarbonate ions in it. And so venous blood can function as a base. It can function as in a way to help us neutralize acids and help us maintain pH. In exercise physiology class, Dr. Mike will talk a lot about how we do this, okay? The thing is called isocapnic buffering, and he'll talk a whole bunch about how we can use the blood to buffer hydrogen produced when you make lactic acid in your muscles, and kind of how that helps us maintain pH, okay? This is how CO2 is going to be transported, though. One way or another, much of this will make itself back to the lungs, okay? And then we diffuse it across into the lungs, and then we breathe it out in that way. So air you breathe out has much more CO2 in it than regular air, okay? One of the science-y sounding things for people that say, like, I don't want to wear a mask is that the mask is somehow like blocking, you're trying to breathe out all of this carbon dioxide, and the mask is preventing that in some particular way. And I can tell you, if you were to breathe air that had more CO2 in it, that's not great for you. But the mask, the CO2 is so small, like it just goes and it's gone. Okay? Doctors been wearing masks for I don't know how long, and they're all fine. Right? You get pissed off if you went into surgery and your doctor wasn't wearing a mask. You'd be like, what are you doing, dude? Don't get your germs all up in my open chest or something. Okay? Anyway, that's kind of what's going on with CO2 transport. All right, where are we next? Gas exchange, blah, 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 vascular system. Okay. Where are we with all of this? It's 12:36. You know what? Let's call it a day. Let's stop here. We'll stop here with the vascular system. Okay? Anybody have any questions? Anything I need to be aware of?